Thank you very much, Liam. I'm very privileged to be here. My thanks to EFIC and to Dr. Wells for the invitation. And I'm an associate professor of radiology at the Mayo Clinic, and I also represent the Spine Intervention Society, and an international and multidisciplinary society dedicated to promulgation of only those evidence-based treatments for the treatment of pain of spinal origin. I have no conflicts of interest to disclose. I do wish to acknowledge the principal investigator I work with at Mayo, Dr. Andreas Butler. Also, another principal investigator at Mayo whose work I will discuss, Dr. Chris Evans, and Dr. Matthias Squarcia from the Department of Neuroradiology at the University of Barcelona. And I'd like to present first a caveat. I'm an interventional radiologist, and I do interventions, so we're talking about delivery techniques here primarily. And the following discussion centers on techniques to minimize nociception with the full and complete knowledge the care of the chronic pain patient requires a holistic approach. I work as part of a multidisciplinary team, so we're talking only about one component of overall patient care. So when we look at contemporary therapies for joint pain, we have systemic analgesics and anti-inflammatories, which were discussed at great length earlier in the day. We have neuroablative interventions. Some discussion will occur later in the afternoon, and this can be applied to the facet joint and the sacroiliac joint with some good justification in the literature, and now new large joint applications. We have intra-articular agents, particularly limited to corticosteroids, local anesthetics, and viscosupplementation, but all of these approaches have challenges. We know that systemic analgesics are challenged by off-target side effects, particularly abuse and diversion, particularly one considers opioids. The U.S. has undergone a 20-year societal experiment with catastrophic results in terms of the widespread use of opioids. Neuroablative interventions, although strongly supported in some areas, also have challenges in terms of patient selection and operator dependence. And intra-articular agents have challenges in inadequate efficacy and particularly durability and systemic side effects. When we consider possibilities for treating joint pain, we can kind of look at systemic therapies versus potential local regional drug therapies. And there's been a lot of discussion this morning about the advancement of the neurobiology of nociception, and this presents us with a tremendous number of additional potential therapeutic targets. But despite all these potential targets for systemic interventions, there's been relatively few of these agents that have reached clinical translation. TrkA sounds wonderful. We'll see what that develops into, but I'm going to focus primarily on local regional drug delivery. And as an interventional radiologist, we have made great strides in terms of our ability to provide very specific anatomic target specificity. But our ability to be successful in treating patients has been largely limited by what's available. We have relatively few agents that can be delivered intrathecally, epidurally, intraganglionically, or intra-articularly, and these agents are virtually always non-selective and of limited durability. We think that local regional therapy has significant opportunities, and that's what I'm going to talk about over the next half hour or so. And we'll talk about targeting the peripheral nervous system using gene therapy, intra-articular space using gene therapy, and a new technique for neuroablative technology that is high-frequency focused ultrasound. First, we'll talk about gene therapy as a construct for pain. For those of you who are not familiar with this, here we're talking about a vector, usually a replication-incompetent virus, which provides the intracellular delivery of an instruction set for a therapeutic gene, the transgene. Most vectors in widespread use are adeno-associated virus or herpes simplex virus. The transgene then harnesses the intracellular machinery for local production of the therapeutic protein or peptide. And our group has used AAV to introduce pre-pro-beta endorphin, an artificial opioid precursor. Goss and colleagues have used HSV to provide pre-pro enkephalin and endomorphine 2, and another group has used AAV to introduce the mu receptors. The point being that you can potentially make the primary sensory neurons its own opioid pump or potentiate its response to systemic opioids. Multiple groups over the last 15 years have shown reduction of allodynia and hyperalgesia in rodent models of chronic neuropathic and inflammatory pain. The query now becomes how to translate this into clinically acceptable treatment. Here, looking at the rodent stage of adeno-associated virus gene therapy, this is an article by my PI colleague, Dr. Butler. Here, this was intrathecal delivery of adeno-associated virus, and using a marker gene, EGFP, we can see transduction of dorsal red ganglia cells in the right-hand panel. The PBS is the control agent, no transduction. And we can also see the EGFP expressed in the extension to the dorsal horn of the cord. The primary sensory neurons provide a great target potentially for gene therapy because they are the aggregation of all nociceptive signaling from the periphery, including our joints, and they're anatomically located in the DRG. They are surgically accessible in rodents, but the key here is they are potentially accessible by image-guided techniques in large animals and humans. We're trying to exploit what we can term a dual selective analgesic treatment strategy. As an interventional pain physician, we have woefully wanted better agents, and as my colleague as a molecular biology researcher has wanted the ability to deliver these agents selectively, and by fusing our talents, we believe we can provide a significant path to clinical translation. The strategies of trying to go directly from small animals, rodents, to humans have so far failed. So our efforts have been directed towards developing a large animal model, which will provide the intermediate step to work out the issues of scale and biologic complexity, which are extraordinarily real. These present challenges in tissue penetration, for example, using AAV or other gene vectors via an intrathecal route, but they provide an opportunity for the selective delivery to the DRG using image guidance. And hence we've developed a swine large animal model I'll spend a few minutes talking about, because there has been no large animal model for this translation until very recently. Well, why swine? Well, they're comparable to human in size. Their spine morphology is very similar. As I do interventions under image guidance, it's very comparable to what I do day in and day out in the clinic. They're hardy and tolerant of anesthesia. They're reasonably cost. They're amenable to basic behavioral training, which gives us behavioral outcomes. And they're generally unburdened by the negative social perceptions of companion animals or non-human primates. Here's an example of a dissected swine spinal cord. And you can see that it does not have a cauda equina. Rather, the phylum goes all the way down to the S2 level and a developed cord all the way down to the lumbosacral junction. There are often 6 spinal segments. But we can see the DRGs very nicely sitting right under the pedicle, exactly as we would see them in a human subject. To illustrate that a little further, here are some axial images, consecutive images, cranial to caudal. And here you can see the blue arrow pointing out the dorsal root ganglia, the primary sensory neurons. And in a swine, it's really very similar, scaled down in size, but there's the DRG, a visible and accessible target for image guidance. We've adapted the work of Krzysztof Bankiewicz at UCSF using convection-enhanced delivery to the deep midbrain to deliver gene vectors. Here we're using a very, very small gauge step needle to directly enter the dorsal root ganglia. Why a step needle in convection-enhanced delivery? If one simply used a quinky-tipped or beveled spinal needle and delivered an agent even at a very, very slow flow rate, for example, 8 microliters per minute, you would see this sort of a track. This is done in blue dye and agarose gel. You'd simply see leakage back along the needle. If, however, you use a step needle, now you see dispersion into the tissue and no tracking back along the needle. So this allows us to deliver an agent into a small volume of tissue, here the dorsal root ganglion. And we're delivering very small volumes, about 50 microliters over about 10 minutes. So it's a very, very slow rate. And here we have shown in a swine model that we have transduced dorsal root ganglia cells using an EGFP marker protein and the control panel below. What does this look like in the clinical suite? Here's the prone animal. Here's a 22 gauge needle directly adjacent to the DRG. We inject a little bit of contrast material that outlines the DRG. And here's that little 32 gauge convection enhanced delivery needle right in the DRG delivering the agent. And this looks very similar to what we do clinically. I use exactly the same scanner that I do day in and day out in a clinical fashion. So direct clinical translation is possible. Now, we would like to have a chronic osteoarthritis model, and almost all the rodent models you saw described earlier in the day used MIA or monoiodoacetate. And this is a very good mechanism to achieve a chronic pain state. It's a chondrocyte toxin. It promotes cartilage breakdown, and it's an established model, particularly in rodents. But we're the first to apply it to a swine situation. And this also allows us the possibility of a behavioral readout. Swine are trainable, and one can train them to walk back and forth along a pressure-sensitive mattress. This is not something new to us. It turns out that in the swine industry, identifying a lame swine is a economic imperative, and Iowa State University and a group in the Netherlands have done this for a couple years using a pressure-sensitive mattress as a means of identifying a lameness. Well, we adapted this to a MIA model in the stifle of the swine, and then we can have them trot across this mattress or walk across this mattress, and this represents primary data. Each of these gray bins is a day's worth of primary data. Swine typically bear more weight in their front legs, so the red and blue dots are all pressure on the front legs. The y-axis here is pressure, ascending pressure exerted by each hoof, so this is all primary data. These are multiple days of data acquisition up to the point of delivery of MIA, and in this control animal, there's really no change. We see an equal admixture of blue and red dots in the front legs and green and yellow dots in the rear legs. Nothing changes over time. This animal received MIA at this point, and now we can see that they move from trotting to walking, and now we see a clear and consistent separation between the pressure exerted by the affected hoof and the non-affected hoof, and we also see increased pressure on the contralateral diagonal front limb. So now we have a quantifiable behavioral readout. It was earlier mentioned today we need a rat reported outcome. Well, here's a swine reported outcome of a physiologic behavior. So we now have a large animal model of chronic pain with a quantifiable behavioral assessment, and this will now give us the opportunity to test analgesic efficacy of gene therapy by intraganglionic delivery in a large animal model for which we have an NIH grant pending. So stay tuned. The next thing I'd like to touch on is intra-articular gene therapy. Joint pharmacokinetics present a challenge for the delivery of therapeutic agents. The systemic delivery of large molecules is constrained by the sieving effect of the synovium, which restricts their access, and direct intra-articular injections of proteins can be futile. They're rapidly cleared by the lymphatics. The half-life of a soluble protein intra-articularly is only about 2 hours. But gene therapy potentially can overcome these barriers, providing durable and local production of a transgene product and avoid off-target systemic side effects. Gene architecture is favorable here in that the dense collagenous matrix of the joint capsule will constrain the gene vectors and the secreted product. And the fibroblastic cells in the synovium and the adjacent fibrous tissue are extremely amenable to a transduction. This work has been going on for about 15 years now. It's been a long struggle, but is finally now achieving translation. What are the potential transgene strategies? One can produce potentially many peptide and protein agents, targeted cytokine inhibitors such as interleukin-1 receptor antagonist, the TNF fusion protein, NBRO, immune modulatory proteins, particularly interleukin-10 and interferon beta, and other anti-angiogenic and potential reparative strategies are being considered. What's exciting is that there are now 2 clinical trials open for intra-articular gene therapy. This trial was just opened at the Mayo Clinic very recently. The rationale here is to use an interleukin-1 receptor antagonist. As has been discussed earlier today, interleukin-1 is a nasty actor. This is a potent mediator of cartilage loss, inflammation, and pain. It's an inflammatory agent. It's an endogenous pyrogen. It acts through lymphocyte activating factor as an immune stimulant. It promotes the presence of nitric oxide, metallic matrix metalloproteases, interleukin-6, prostaglandin E. It causes proteoglycan deletion from cartilage, inhibits chondrogenesis, and alters bone turnover. This is a bad actor. But it can be opposed by interleukin-1 receptor antagonist, a naturally occurring small glycoprotein. It binds to the IL-1 receptors on the cell surface. It does not provoke a cellular response that's been detected to date, and it will block the biologic activities of interleukin-1. And here we can see we're transducing cells in the synovium or the fibroblastic cells adjacent to it and secreting this therapeutic protein into the synovial fluid. The supporting evidence, there's good therapeutic gene expression in the rabbit and equine models that have been published. A safety and biodistribution study has now been completed and an IND has been granted by the US FDA. And here are some examples of a marker gene, green fluorescent protein, here being expressed in synovium. These are equine synovium. And here in chondrocytes. So we know we can transduce them. And here is some unpublished preclinical data in an equine model where the interleukin-1 receptor antagonist has significantly reduced lameness in this equine model. Clinical trial currently being opened. The target here are those patients with moderate knee osteoarthritis. It's a phase 1 safety study with secondary MRI and functional outcomes. The agent here is self-complementary recombinant AAV, serotype 2.5. It's going to be delivered by just simply an intra-articular injection using a CMV constitutive promoter. I'll talk about that a little more later. And 3 dose levels, and this is being conducted at the Mayo Clinic. So it's finally coming to clinical fruition. Another trial is also open in Leiden in the Netherlands. Here we're using an anti-inflammatory cytokine as the transgene product, interferon beta. They're also using a very novel approach using a regulated promoter which upregulates gene production or gene function only in the presence of inflammation. So you get it when you need it. Supporting evidence here, they've demonstrated efficacy against collagen-induced arthritis in mice, monkeys, and rheumatoid arthritis in humans in a non-gene therapy application. And they've shown prolonged therapeutic efficacy in rat adjuvant arthritis. A safety and biodistribution trial has been successfully completed. Here the target population will be rheumatoid arthritis in the wrist joint. And it's again a safety study open at Leiden. So this is very exciting. We now have clinical translation available to us. The last thing I'd like to touch on as a new technology that we'll likely see in the clinic in the near future is focused ultrasound. And this has been around again for many years, but not readily applied to joint pain. And this has been used predominantly in the treatment of endometriosis or uterine fibroids. Here we know that there's a strong competitor for this, that thermal neuroablation of facet innervation has some of the strongest evidentiary base in interventional pain procedures. But it still has challenges in operator dependence. That thermal ablation based on delivery of an RF needle requires a significant skill set in the operator. And you really can't use advanced image guidance. It usually relies on fluoroscopic two-dimensional guidance. And you need to use large electrodes penetrating the skin. So here's an example, a dissection, dorsal, ventral. This is the lumbar spine. Here's the facet joint. Here's the mammalo-accessory ligament. And here's the medial branch of the dorsal ramus passing underneath it. Here are the intermediate and lateral branches. And the operator must place that needle very precisely at this point to achieve an appropriate thermal ablation. And that requires a significant skill set. Here are the small articular branches, which are the ultimate target. And here are the examples from the SIS guidelines in correct needle placement. Certainly something that's well achievable by experienced practitioners, but it does involve a skill set. Focused ultrasound utilizes high-frequency ultrasound focused at a very specific point in tissue space to achieve tissue heating greater than 55 degrees centigrade to neurocoagulation. And this uses MR guidance. The anatomic structure guidance is done with 3T MRI, allows us to avoid vulnerable structures, and it also gives us MRI thermometry. We get real-time assessment of the tissue volumes which have achieved coagulation levels, and immediate visualization of the tissue outcomes. Hence, you can iterate during the procedure. You plan, you sonicate, which may be 20 to 40 seconds, and then you can see the lesion and you can determine additional lesions as necessary. And this has already achieved the European CE mark in 2013. It's not yet has an IDE granted in the USA. And here's an example of a commercially available unit, and the sonication unit is simply built into the table. The patient simply lies on their back in the MRI scanner during the targeting and the procedure. The potential benefits: superior anatomic guidance versus planar fluoroscopy, real-time confirmation of the energy delivery to the target, the potential to target capsular articular branches, leaving medial branch innervation of the multifidus intact, no radiation, no skin transgression. So what's the evidence? Focused ultrasound has demonstrable ability to disrupt nerve conduction via thermal necrosis in a pig model, a swine model. Here the strategy was to target the capsular margin. Here's the transducer. The energy is focused at the posterior capsular margin where those articular branches enter the joint. And this potentially could preserve multifidus innervation. And this has been validated in a swine study. And there's now a phase 1 safety study with some early efficacy data in the literature. The inclusion criteria here were a positive response to a prior facet intervention. There were no adverse events. The challenge here is 180 minutes in an MRI scanner. Admittedly, this is a phase 1 trial, but if this is going to be a clinically viable procedure, it's going to have to be significantly sped up. The 13 patients in this phase 1 trial who had follow-up all had improvement around 50% or greater in their pain and functional recovery. And another pilot study, this from the University of Barcelona. Selection criteria, again, positive response to anesthetic blocks, 4 to 8 sonications per joint, no adverse events, and about 50% improvement in functional and pain scales. Now, an alternative strategy was just published last month by Memorial Sloan Kettering in New York. Here, rather than focus on the articular branches at the back of the joint, which requires you to sonicate all the way along the posterior aspect of the joint, here they're focusing, just as we would with thermal RF, on the medial branch itself. Cross-sectional medial branch targets have been well established. We know that bone deflects and attenuates ultrasound energy, and the cortical and cancellous bone will have relatively little transmission of heat or energy to the adjacent soft tissue, and CSF and intraspinous venous plexus can act as a heat sink. So these factors potentially protect the neural canal and neural elements from any energy deposition. And in this study, again done in an ex vivo model, they did all the right things. They first validated in the swine model that indeed the medial branches of the dorsal rami have the same distribution in humans, and they do indeed run at the juncture of the transverse process and the superior articular process. And here, moving the transducer to a more lateral position, they can target the medial branch at that juncture. And they did demonstrate in the swine model that you can achieve neuroablative lesions, that these lesions were demonstrable on imaging, they were demonstrable at necropsy, and there was minimal adjacent injury. And they delivered a fairly small constrained needle size without significant injury to the adjacent multifidus. So this is very exciting, and this is a strategy that we are going to seek to employ at Mayo. So MRI-focused ultrasound, I think, has great potential to provide reproducible neuroablation at well-defined anatomic targets. Its potential application to other neuroablative targets is certainly real as well. Lateral sacral nerves, which can be challenging to target with planar fluoroscopy, and genicular nerves at the knee. But it must overcome cost and time challenges. So in conclusion, a post-steroid era, I believe, is nearly upon us in gene therapy and the treatment of radicular and joint pain syndromes. It's close to realization. Gene vectors might solve the dilemma of durable delivery of therapeutic agents to synovial joints. And MR-focused ultrasound has promise in providing better cross-sectional guidance and reproducibility in neuroablative agents. So I'd like to thank you for your attention, and as a member of the Spine Intervention Society Board, certainly invite you to potentially come to our European Congress in Lisbon next month, and keep in mind that we'll have our 25th annual scientific meeting in San Francisco next year. Thank you very much.
Thank you very much, Dr. Mouse, for that very stimulating presentation. Has anyone got any questions for Dr. Mouse? Well, sorry.
Yes, I have a question. Sure. From Switzerland. The half of my patients were operated in the back. Is that a problem for your technique for MRI ultrasound?
For focused ultrasound, I don't believe it will be, but that's something that will take some validation. All the initial phase 1 trials have all been done in virgin back, so to speak. So I think that's something of concern, but I would not think it likely to be an issue.
Okay.
But a very good question. Yes.
So it's very interesting for me, who is a high volume practicing interventional pain physician, and I do about, let's say, 20 procedures a day, have about 5-6 denervations based on a CIS guidelines, obviously, following with 18 gauge radiofrequency using fluoroscopy. When you listed as a time interval of the MRI of 188 minutes, even if you reduce it to certain reasonable time interval, the issue is obviously the time and also cost of the procedure itself. How that applies, considering and do you know what will be, well, I saw the Gulati study good friends from Sloan, the time interval of the denervation of the ultrasound-based radio frequency, is that feasible to basically offset the cost of such a long-term
All
procedure?
remains to be proven. Those
Okay.
are there's absolutely the questions that need to be asked. And I think that the reason to even consider developing this is the heterogeneity we see in practice with the needle-based ultrasound techniques. In good hands, in practiced hands using the SIS guidelines, I think you can get superb results at a reasonable time and a reasonable cost. But there may be challenges of anatomy in some patients that could potentially be overcome by cross-sectional guidance. And I think there's the possibility of providing more reproducibility of targeting. I absolutely admit 180 minutes in an MRI scanner is not tolerable nor ultimately feasible cost-wise. But one hopes that this can be significantly reduced. If it cannot be significantly be reduced, then this will never be a viable product. But I think it's still worth investigating.
Yeah, I mean, it takes me literally about 7 minutes to do the
Right.
innervation of the
Right.
facets.
Each individual sonication is about 20 seconds. So these are not, individual lesion creation is not necessarily a time producer. It's the whole rigmarole of getting the initial scans, targeting, and those are the sort of things that with development can potentially be substantially improved. But we'll see. Time will be the test.
I think, most of the patients that I treat have really abnormal spines. And this might be a much better way of dealing with those type of patients. Would you not think so?
If you have big osteophytes that impede your access to the medial branch, it's potentially a way of getting around that. It may find a niche as a treatment modality for those patients who simply have those sort of anatomic challenges that make them less amenable to the standard technique. But it will always have to be measured against the RF needle-based standard.
But thank you very much, Tim. That was very stimulating. Thank you.